Good morning. You're going to hear some more in-depth lectures from my colleagues coming up after. I wanted to start off with a little general overview and give you a little bit of a general overview of spine, how I think about the day, seeing spine patients and pulling apart their diagnosis and that sort of a thing. So a little general background. So first of all, does this person have pain? Can you tell me if they have pain? You see this dark disc here, you see this annular rent. Are they having pain? They came into my office about 10 days post-motor vehicle accident, clutching their MRI report that said they had this, sent in by their attorney. Should I be signing them up for a lumbar disc or a lumbar fusion? You think that this annular tear, maybe the prostaglandins from the nucleus pulposus are leaking out, irritating the nerves, causing a chemical reaction, causing radiculopathy, or maybe the tear is irritating the annular nerves running around the annulus, causing back pain. Clearly, it's right there on the MRI, right? What about this patient? They having pain, they have a little bone spur, a little retrolisthesis, a little bulging disc. Are they having pain? How about this one? This guy's clearly in pain, right? Look at that. This guy can barely walk, right? Is he having low back pain, neuropathic pain? Does he need a 5-level lumbar fusion? What are we going to do with this guy? Okay? Couple of key points. There are multiple studies out there over the years showing a very high percentage of significant arthritic findings and changes in asymptomatic patients. Okay, that's the first thing. Clutching the study is not the answer. Virtually everyone in this room, if we MRI'd your spine, whether you're having pain or not, are going to have significant findings on your MRI. Okay? This is a lovely study that was done recently. It's a meta-analysis in 2015, American Journal of Neuroradiology. They took 379 different studies that addressed this subject. They weaned it down to 33 studies that they thought met their strict criteria. There was over 3,000 patients, and this is what they found. Okay? Look at this. 30-year-olds, over 50% with disc degeneration. This is age-specific prevalent degenerative spine in asymptomatic patients. The best word is missing from the slide, I apologize. Okay? 50% of 30-year-olds, 80% of 50-year-olds, disc degeneration, signal loss, facet degeneration, disc protrusion, disc height loss. Look at these numbers. Asymptomatic patients. Okay? Just because you see findings on the study does not mean that we should be running off to the OR tomorrow. Okay? Does this patient show up in your office? It's just reserved for the spine service and the spine colleagues. You get this guy in your office, numb and tingling everywhere, and I still don't understand what this is. Fire shooting from his head. In case you weren't sure he was not happy, he drew in a frown. There's no frown on my diagrams. Anyway, I find these really interesting, and when you see findings on a study, you have to back up. When you see all of these crazy diffuse symptoms, you need to back up. The key to a good outcome in spine starts on the diagnostic end. The time spent on the diagnostic end of the process is well worth the money and time. Okay? The need for diagnostic specificity is the whole key. Okay? Most things get better, a little anti-inflammatory, muscle action, physical therapy, activity modification, time heals a lot of things, right? But after that, if they're not getting better, you need to go on a search, okay? The more specific the diagnosis, the more focused the treatment, the better the outcome, okay? Back pain is not a diagnosis. It's a symptom. I see it all the time. They come in, they have 6 months diagnosis back pain. Sciatica, not a diagnosis. Sciatica is a symptom. Why are they having shooting arm or leg pain? Okay, diagnostic specificity is the key place to start. When I see a patient like that with all of these problems, when I see findings on a study, the first thing I try to do in the busy, crazy day is I split it up into 2 areas in my brain. Is this just mechanical, musculoskeletal, neck or back pain? Or do I have more to worry about? Are there neurologic symptoms and neurological findings? Okay? And as you're going through this, the mechanism, the history, the symptoms what you find on physical examination, what you see on the studies needs to add up. If it doesn't add up, you're not going to have a good outcome. If it adds up perfectly, you have a great diagnosis, you're going to have a very good treatment outcome with whatever you choose. It's the ones that don't add up well that become the problem. Okay? Very quick review. We don't have enough time to go through much anatomy today, but quick review. Cervical and thoracic spine, you're still at spinal cord level. You can compress the nerve rootlet coming out the side, as you see here from this disc, or you can compress centrally in the cervical, thoracic spine, the spinal cord, and they present differently. In the lumbar spine, the spinal cord typically ends around the T12L1 level with the conus medullaris. All the nerve roots come off in a bunch there and hang down in the cauda equina area. You can see that on this study. You see the MRI, you see the conus medullaris, T12L1, nerve rootlets hang down, big giant herniation. Okay? Different symptom complex in the lumbar spine, no spinal cord at that level. If you compress a nerve root at any level in the spine, you get very focused symptoms specific to the nerve root distribution, right? They get shooting pain, numb, tingling, burning, electrical sensation, dysesthesias, hyperesthesias, maybe anesthesia. If they get weakness, it's a lower motor neuron type of an injury. They get a flaccid weakness. They get a depressed reflex, okay? Nerve root compression. The beauty of nerve root compression and neurological issues in the spine is that we have a good roadmap. Again, time does not permit to go through this. This can be found in any textbook. We can go over it in the breakout sessions. But if you pinch a nerve root, you get very focused symptoms. You pinch the C6 nerve root, you're going to get symptoms down the arm on one side, the left side, down to the thumb and index finger. You're going to have specific focal weakness, right? You're going to have specific focal reflex deficiency, right? So your dermatome, very focused to one side or the other, dermatomal, myotomal. Even in the thoracic spine, you'll be shooting around on one side in a very thin T5, T6 distribution, very focused. One side or the other, same with the myoterm, okay? Adds up very perfectly. Great roadmap. Very intricate, but we have a great roadmap to figure out what's going on. And typically, you know what's going on before you get the study. The study's diagnostic. They come in, they have these symptoms, these findings on exam. This guy probably has an L5-S1 herniated disc on the left. If he doesn't, that's a big question mark now, okay? Spinal cord compression. If you're at cervical or thoracic spine level, you can have central spinal cord compression. Here you see compression, you see myelomalacia cord signal changes. Okay, and this person's probably having myelopathy, right? These are diffuse, non-focal symptoms. They may not even have pain. They may just come in with tingling and numbness and heavy feeling in both of their arms and hands from the elbows down. Diffuse, not dermatomal, not focused, maybe both sides. This lesion could cause symptoms in the legs. This can cause numbness and tingling in their right leg and weakness in their right leg, okay? And their symptoms are diffuse, their weakness is spastic, rigid, they're hyperreflexive. This is an upper motor neuron type of an injury, right? They complain about being off balance, gait, coordination, fine motor skills functions in the hand. They can't button their shirt. They have to walk holding on to things. I've seen people walk down my hallway holding on to the wall to get to the x-ray. We know what's wrong before they get there, right? Okay? And in a bad case, you get down to bowel and bladder dysfunction with this. So spinal cord compression, different level of concern and injury, different presentation. Of course, you can have both. You can have a milder radiculopathy. You can have a mixture of these. But when you get these diffuse symptoms, you got to be worried about the spinal cord. Lumbar is different. You're at cauda equina level. The spinal cord ends, T12L1, you're cauda equina syndrome. You compress the cauda equina anywhere, like this giant herniation, right? Anywhere along here, you get saddle anesthesia or paresthesias. Sometimes these patients just present with urinary difficulties. What's the urinary difficulty? It's not stress incontinence. They sneeze, they laugh, they cough, they urinate a little bit. They have frequency. They have urgency to, I got to get to the bathroom quickly. That's not the problem they have. They have retention issues. Difficulty starting their urine. They stand there. The guy stands there, and it takes a while to get going. He can't get it all out. Or they have an overflow incontinence. Their bladder has 1,000 cc's in it, and they keep urinating multiple times. I go 7 times an hour, a little bit, because it just comes out on top. So these are the type, retention urinary issues. They may complain of just intermittent numbness and tingling around their anus or their genitalia. It's this distribution. The lower sacral nerve roots, saddle anesthesia, medial thigh, okay? This is a real urgency, and this is probably the thing that I think gets diagnosed the slowest wherever the patient is, whether they're on the floor in the hospital or they're home, because it can be subtle, okay? Later down, and it could start off with very slow symptoms, but down the road they will get bowel and bladder dysfunction, rectal tone problems, and weakness in her lower extremities. The other thing that makes neurological pain evaluation difficult is there's multiple other things that cause neurological issues that can mimic it, right? You have median neuropathy, carpal tunnel syndrome, and C6 nerve radiculitis gets confused a lot. C8 radiculitis and an ulnar neuropathy. C5 with the motor weakness and pain to the side of the shoulder and deltoid function weakness often gets confused with rotator cuff tendonitis and rotator cuff weakness. Upper lumbar nerve roots get confused with groin and thigh pain from hip arthritis. So there's a great map, and if you know the anatomy and distribution of things, you can really pull things apart, but it is quite complex. The difficulty with mechanical pain is that we don't have that great roadmap. It's not as easy to pull this apart. It's very multifactorial. People with back pain have pain over here somewhere. It hurts over here, doc. They rarely go, my left L3-4 facet is killing me. I rarely hear that. So you have to pull it apart. And it's multifactorial. And you may have an arthritic disc and bad facets at multiple levels. You may have muscle pain. There's a lot of things going on. Don't have the same good roadmap. Difficult to pull it apart. Not as worrisome and concerning from a neurological standpoint, obviously, but concerning from that standpoint. Let's do a little bit of anatomy. So, vertebral body. This is the pedicle where a screw would go. This is the spinal canal where the nerve is running. Lateral recess area, the posterior facet. The disc is a specialized motion segment, a specialized joint. Here's the neural foramen. The facets overlap, allow for flexion and extension, right? They allow for motion, but stop slippage, okay? And it's all three joints together. That's the problem with spine, is that the lumbar spine's multiple segments, but each segment also has three joints associated with it. Makes it difficult. The disc is not a jelly donut with some goop in the middle that you see on the internet. The disc is a highly specialized joint, multiple concentric rings around that allow for rotation, flexion, extension, side bending, and give tremendous stability as well as compressive forces stability, okay? Everybody familiar with Penrose diagrams and Escher pictures? You've seen this picture before? Very beautiful, intricate, well-detailed, gorgeous-looking picture that has nothing to do with reality, right? It flows down, comes off, and it's at the top of the waterfall again, and it flows. You should see how many pictures on the internet about discs and disc herniations and treatment for disc herniations are Escher diagrams. They are 3D images placed onto a 2D picture that has nothing to do with reality, okay? Buyer beware when you're looking on the internet for things. A little plug for our department and the spine surgeons here. We have a great department. We have well-trained, board-certified, fellowship-trained orthopedic spine surgeons here. Being at a hospital of this caliber means something. Having that training means something. There's a lot of stuff out there. Here we have QA committees, we have M&M conferences, we have conferences where we sit down and go over difficult and interesting cases. We challenge each other. It's very helpful and a very useful process, okay? I know spine surgeons in New Jersey. There's a guy, he flies up, he has offices in several states, flies up here, sees patients occasionally, takes them down to Jamaica to do his total disc replacement in Jamaica because it's not okayed here yet in the United States, his particular disc replacement. We got a guy who comes up from Florida, does a bunch of procedures at a surgical center, doesn't even meet the patient, just shows up, the docs have it ready, does a bunch of cases, flies home that night, okay? These are real things going on. This does not happen here, okay? That's not what's going on here. There's thoughtful, collegiate atmosphere of people trying to do the right thing, okay? Look at this case, right? Normal discs, degenerative discs, okay? I say to you that if your patient is offered a percutaneous discectomy because they have discogenic low back pain, and you think you're going to stick a scope in here and clean this up and they're not going to have pain after that, the studies don't bear that out. The studies bear out progression. Anything, even a tiny needle stuck into a disc space, will accelerate degenerative processes. If he's offered that, I recommend a second opinion. Our pain colleagues are really trying very hard to help us on the roadmap to mechanical back pain, which is not an easy process, right? To do injections to try to narrow down and focus the pain generators. Unfortunately, this doesn't always add up to the right finding, okay? This is another little piece of information, but it doesn't give you the answer. And again, I say to you that if your patient is offered an SI joint fusion, I recommend a second opinion. If your patient is offered a multi-level lumbar spinal fusion or cervical spinal fusion based solely on a discography study, I recommend a second opinion for you. If we do narrow it down to the spine, the problem to the spine, what could be done? You can repair something, you can excise it, you can decompress it, reduce it, and stabilize it. Notice that fusion is not on the main list of things. You can directly repair an odontoid fracture, a fracture, a compression fracture or a burst fracture where you span across it, you don't fuse, and you come back later and you take that out. These things make sense for certain cases. You can decompress. What does decompress mean? Whatever's pinching the nerve, get it off. Disc herniation, piece of the vertebral body, a facet cyst. You make a laminotomy here to open up the window where the nerves are running. Okay? This is the most common thing we do, a laminectomy. The key to a laminectomy is making room for the nerves, but not disrupting the pars intra-articularis between the joints, so as not to destabilize the case. This is the hardest thing. The hardest thing conceptually in that you want to make room, you want to do a partial medial facetectomy and undermine this to open up this nerve rootlet, yet you don't want to remove too much that you destabilize them. Okay? And you remove too much, they're unstable. You remove too little, you add a little bit of arthritis, a little bit of motion that's still going on, a little bit of hypertrophy, and then all of a sudden, they're back again because they have recurrent lateral recessive stenosis. You can reduce something, meaning put it back in place. Reduce it, can decompress things. That doesn't need a decompression. It needs to be put back in place. And you can help mechanically by putting something back in place. This guy's grade 2 spondylolisthesis, bone on bone. He's way leaning forward, hanging over like that. You got to get his head back under his pelvis, so reduction helps mechanically. Stabilize. If the spine is unstable or you need to destabilize because you need to decompress and remove the facet joint, then you need to stabilize. That is the role of instrumentation, to hold something in place until fusion occurs. It's temporary. This won't last forever unless it actually turns to solid bone the way that a fracture would heal. The role of fusion, that is the role of fusion, to get this to heal with bone, so you're no longer depending upon your instrumentation. This is an onlay graft. Everything's always under shear. This is an interbody graft. People hear about interbody grafts. The beauty of an interbody graft is the interbody area has a tremendous surface area for fusion, and the graft is under compression, which is how bone heals. This is continual shear forces, doesn't heal as well. When does fusion make sense? People ask me this all the time, nurses and people in healthcare, all the time. Why is this guy getting a fusion? Does he need a fusion? Does this guy need a decompression fusion? Think about stability. A fusion is predictable for stability. If you have instability, spondylolisthesis, scoliosis, kyphosis, surgical destabilization, a fracture, and you fuse, it's a home run. They're going to do great. You get into trouble, and it's not very predictable for fusions for arthritic back pain or any other back pain or neck pain when there's no real instability present. I'm not saying that you shouldn't do it. This guy might do great. You might localize it to this. The rest of his spine looks great, and he might do great with a disc replacement or a disc fusion. He might, but you need to cross the T's, dot the I's. You really need to be sure, because these are the cases where you hear they had a whole bunch of surgery and they didn't get any better or they got worse. Okay? When you fuse, you must be concerned about alignment. The head needs to be over the pelvis in both planes. If you fuse off to the side, you're going to get adjacent level disease. If you fuse flexed forward, you're going to get adjacent level disease and back pain. And my two partners took this patient and did an osteotomy and did this to them, put their head back over their pelvis. Tremendous operation. Had it been done correctly the first time, wouldn't have needed it. We have intraoperative CT. O-arm guidance, okay? These are tools. These do not, even robotics these days, these do not replace expertise and experience, okay? These are tools to be used by the surgeon. It's like your car. You wouldn't pop your kids in the car and hit the automatic button. Oh, my car drives for me. Does it really? I don't think it really does. We're not there yet. Maybe we'll be there one day. We're not there yet. And we're not there with robotics and image guidance yet. You need the surgeon there. What approach is beyond the scope of this? But I tell you, whether it's anterior, posterior, lateral, minimally invasive, whatever that means, okay, you must get the job done. If you didn't go from here to here, I don't care how small your incision was, how quickly you did it, which approach you did, who cares? The point is, you have to reduce it, decompress it, get it lined up, open up the disc space again, open up the foramen, put the screws in the right place, and use the right bone graft material so this actually fuses over the next 2 or 3 or 4 months. Because if it doesn't, it's going to fall apart. So if you didn't get from here to here, you haven't helped anyone. And it doesn't matter what marketing ploy you've used, you want to get to the right place. The future of spine surgery, in my opinion, motion-sparing stabilization. Here's disc replacement, cervical spine, a lumbar spine. Much more useful, much better results, much better literature for cervical disc replacements, okay? But if you have arthritic facet joints and you preserve the motion, you haven't helped anyone because now you have arthritic joints moving around. If you have instability, that's the biggest problem. If you have instability, these things don't work well. You have to have good stability in the posterior joints to do replacements right now because each motion segment is not just the disc, it's 2 posterior facet joints, 3 joints, and we're not there yet. But that's the future. That's what total joints are. Total knees and hips, wildly successful. We're not fusing hips and knees anymore usually, right? We're not there in spine yet, okay? That's what we want. I think the future of spine is the integration of minimally invasive techniques along with integration with navigation systems that we have and robotics and adding to that and using those to get motion-sparing stabilization. So you're going to correct your listhesis or your scoliosis or do your decompression and still allow for motion. That's where we're going to go to in the future, in my opinion. Anyway, that's all I have. I hope you guys got a little something out of that. Thank you.
Cool.